What's up, everyone? This is Bo from Buzzwords Med. As always, I'm here with Bobby. We run a podcast called Buzzwords Med, the med school drinking game. And this is one of our first episodes. We've actually tried this cardiology episode twice now. So hopefully, if you're seeing this, it finally worked. Bobby, today, what do you have for us in regards to your drink?
I am drinking Hydro Haze from Warp Wing Brewing Company. It's an IPA. What do you sip on?
Nice. I'm drinking the Flying Embers Hard Kombucha. It's actually grapefruit flavor with a hint of thyme. Not
Very
thyme.
Cool.
Or a theme.
I thought it was pronounced thymine, but shows you what I know.
Thiamine, high yield. If you want more about thiamine, check out our vitamins podcast. All right, Bobby, crack him if you got him. All right, everyone. So today we have a cardiology episode that's going to be focused on some aspects of the high yield EKG findings that you'll find for the USMLE exam. If you're looking, you'll see a beautiful rendition of the heart designed by yours truly. You'll see a similar design in relation to the lungs that Bobby is wearing currently on his shirt.
Should we jump right into it, Bo?
Let's jump right into it. Tell us what you see in this EKG. Poetry.
I see the text on the top saying chest pain, which clues me in a little bit. But what I also see for those at home who are listening on audio is in leads 2, 3, and AVF, I actually see some ST segment elevation relative to the baseline with some peaked T waves, which would make me concerned about an inferior myocardial infarction, probably in the right coronary artery branch specifically.
All right, Bobby. So behind me on the next slide will be the correct answer. If you don't mind, click into the next slide. Perfect. So what was your answer again?
I said a RCA infarction.
Perfect. So if you don't mind moving me down the screen a little bit. Fantastic. So you're correct. An inferior wall infarct. You saw that because there was an EKG involvement in leads 2, 3, AVF, which often, especially for the USMLE exam, signifies an RCA lesion. So Bobby, when we think ST elevation, we think myocardial infarction, but there are multiple reasons someone could have an ST elevation outside of a myocardial infarction. Would you mind telling the listener and telling the viewer other reasons someone could have ST elevation, particularly high yield reasons for the USMLE exam?
Sure thing. So the first two things that come to mind would be pericarditis and also bundle branch blocks, both left and right, can cause ST segment elevations. Am I missing anything?
Nope, that's fantastic. The one thing I would add is ventricular aneurysm. So that would be the case for the exam where a guy comes in, he has an MI, he's in the hospital for a little bit, he goes home, and then he decompensates a month later, and you get an EKG in the emergency room, and there's ST elevation everywhere. You would think about a ventricular aneurysm in that case.
Cool.
All right, so the next slide is actually going to have one of those reasons that you just mentioned. So let's see if we can decipher which reason it is.
Okay. Well, I think I am blocking most of this, so I will move myself.
Yeah, get out of the way.
Here. There you Sorry about that. So I'm seeing, kind of some ST segment elevation and some peaking again, and a little bit of widening of the QRX complex in leads V1 through V3 especially, and then a little bit in V4 as well. So I would think this is probably a left bundle if I had to guess.
Fantastic. So this is classic left bundle branch block. For the listener at home and for the viewer, you got to put this image in your mind. So if you're listening, if you're driving home and you're listening to this over our podcast, pull up YouTube, and look at this image because this is an important one. You're seeing the classic Brugada sign found in left bundle branch block where you have that deep S wave petering out to a peaked ST. You'll see that in V1, V2, V3, and then you can see the rabbit tail, or the rabbit ears, on V5, V6 most frequently. It'll be widened QRS because remember, with a bundle branch block, the electricity is now not going through the Purkinje fibers and the His bundle and all that good stuff. It's actually just going to the right ventricle because the left bundle is blocked. And then from the right ventricle, it goes to the left ventricle. And because of that, you have that widened QRS. All right. Very well done, Bobby.
Cool. And for the listeners at home, just a quick little tip to help burn this into your brain. Turn your screen brightness all the way up so it gets burned into your corneas first, and then you'll never forget it.
I'll drink to that. It's those tips that really make us stand out. All right, one more etiology of ST elevation will be on the next slide for you, Bobby.
Alrighty.
Let's see if you can get it. Beautiful.
Well, here, let me make you a little bit smaller just so we can see that.
Make me a little smaller.
There we go. Perfect. So, now that I've sufficiently stalled for time, it looks like we are having some ST segment elevation as well as some like kind of peaking T waves in pretty much every lead, but especially V2 through V6 to 1 to AVR and AVF. I mean, with this widespread of ST segment elevation, now think about something like pericarditis.
Right, and for the listener at home, can you describe what's happening with the PR interval as well?
Sure thing. So the PR interval looks a little bit widened. It's especially obvious if you look in lead V4, the blown up lead that's highlighted here at the bottom, but it's definitely wider than normal.
That's a good catch. I didn't realize the PR interval was much widened, and I think you're right. I think it's just on the cusp of being around 200, so you're right. You might even have a first degree block here, which is a good finding because that's not even what I was getting at. I was getting at the depression of the PR with the elevation of the ST in combination, creating that picture that is so classically known for pericarditis. Well done, you picked something up. Yeah.
I'll drink to that too.
If you're new to our channel, guys, especially our podcast listeners, they love the slurping noises. So let's make sure they get it.
We do a bass boost on the mic just so you can hear it even better. Maybe we'll add some reverb for you guys too.
Reverb. Fantastic, Bobby. Let's continue. Our listeners are anxious for more. As am I.
I'm anxious too.
Fantastic. Our images are perfectly placed.
Nice. Okay, so for this tracing, what I'm seeing is what I've described as grouped beats. So you can kind of see, two Q wave, like QRS complexes, and then a P wave that's not conducting a beat, and then another P wave that's not conducted, and then another pairing of two P waves that are both conducting their QRSs. So if I had to hazard a guess on this one, and I'd also say that the PR interval seems to be relatively constant for the beats that are conducted. So I would say that this is probably a second degree heart block, Mobius Type 2.
Perfect. And what would the next step be for this person?
So Mobius Type 2 and above, so that would also include third degree heart block, is pretty concerning for the cardiologist. So they would definitely get a pacemaker.
Yeah, I'm concerned too, just looking at this. So pacemaker makes a lot of sense. So Mobius Type 2, just to kind of recap on all the high yield Bobby just described, because it was a lot, is it's a block. So heart block category, Mobius Type 2, you have normal PR intervals and then dropped beats. So you can see that here, there's some conduction and there's lost conduction. There's no prolongation of the PR at all like you'd see in Mobius Type 1. Mobius Type 1 you can think about as an AV node fatigue syndrome, where the AV node gets more and more fatigued as it beats. So then you get the longer and longer PR intervals until it drops in, until it just needs a break for a second. But because Mobius Type 2 often occurs distal to the AV node, so it occurs in for example, the His-Purkinje fibers, it's kind of an all or nothing phenomenon. So there's beat, beat, nothing, 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 beat, beat, nothing, nothing, nothing. And that is classic for Mobius Type 2, and it is very dangerous. It often is a sign of underlying ischemia, fibrosis. Something's not going on in the heart like it should, to the degree that it needs to be, and therefore a pacemaker is indicated. Well done, Bobby.
Cool. Okay, so in this tracing, I'm seeing QRS complexes that appear to be pretty regularly spaced, and I'm also seeing what looks like P waves that are pretty regularly spaced, but they are not spaced together. So sometimes the P wave, like if you look at this second beat here, it almost looks like where it's supposed to be. But if you look at all the other ones, there's basically no preceding P wave before the QRS complex. And some of the P waves are actually kind of stacked on portions of the QRS complex are actually on the T wave as it is right here. So if I had to hazard a guess, I would say this is probably a third-degree heart block where the atria and ventricles are just completely dissociated and kind of vibing independently.
Fantastic. And that guess that you hazarded was correct. So this is a third-degree block. There is no relationship between the P waves and the QRS complexes. You can tell that pristinely as Bobby did because the QRS complexes, unlike the Mobius Type 2, so go look at what Mobius Type 2 just looked like with the grouping. This one, the QRS complexes are perfectly spaced out. Another hint that the ventricles are vibing, as Bobby said, to their own rhythm and are not worried about what the P waves or the atria are doing. Fantastic. And this patient would also get a pacemaker.
Okay, so what I am seeing is QRS complexes that are pretty irregularly spaced relative to each other and an erratic or pretty wandering baseline. I can't really see any P waves or T waves. So I would say that this is probably atrial fibrillation.
Right on. And so let me give you a little scenario real quick, and this is the high yield takeaway for the viewer and listener at home. Let's say this is a new onset atrial fibrillation in a 68-year-old female with no past medical history. What would you start them on?
I would start her on heparin.
Fantastic. So heparin in the hospital, and then when she leaves, she's like, "Oh, I feel better now. I'm ready to go home." Are you gonna just let her go home without anything, with some aspirin, or with some therapeutic anticoagulation?
So I would do a heparin bridge to warfarin, but I'm also not 100 years old, so I would potentially consider a NOAC or DOAC if she didn't have any other like valvular issues.
Fantastic. And can you walk us through your thought process and what acronym you were considering when you made that decision?
Yeah, so this is super important to know both for testing purposes and also it comes up on the wards a lot. But the decision of whether or not to anticoagulate somebody is for AFib is based off of their thromboembolic risk. And the scoring system that's typically used is the CHADS2-VASC score. And if you have no points, which means you don't have any thromboembolic risk factors, then you don't need anticoagulation. If you have 1 point, people will typically either say aspirin or like discuss it with your provider and then maybe do heparin, bridge to warfarin, or one of the other, mechanisms already discussed or methods already discussed. And then if you have 2 or more points in this CHADS2-VASC score, then you do need anticoagulation. And each letter stands for something. So as typical in medicine, it's mnemonic. So the C stands for CHF, H stands for hypertension, the first A stands for age, so if you're over 65, you get 1 point. The D stands for diabetes. The S is for stroke or TIA, which is actually worth 2 points, hence the 2. And then VASC, so the V is for like vascular disease. So if you've had like peripheral artery disease or like carotid artery disease, that gets you a point. And the second A is for age over 75. So if you're over 75, then you would get 2 points. And then the SC is for sex. So if you're female, then you get 1 point. So our 68-year-old female gets 1 point for her age and then 1 point for being female. So she should get anticoagulated with 2 points.
Beautiful. Well explained. I have nothing to add, except that you are fantastic and you have value.
Preach.
That was for you, the viewer, and the listener, not Bobby.
Jamie, cut that part out. It was for me.
Jamie, amplify, enhance.
Jamie, fast boost. Okay, so I think there is one more in here. Oh, what's going on and what are you going to do for this person?
For the listener at home, Bobby has presented me with an EKG strip with no lines on it. making me think of asystole. So a patient entered the ED or the hospital with asystole, we would immediately start ACLS protocols, which would include chest compressions, epinephrine, but this is not a shockable rhythm. You would not shock this person, and you would not give this person amiodarone. So I think a good teaching point, I'm kind of hijacking Bobby's EKG, but I think a good teaching point is if someone is in VFib and VTAC, you can shock them. Those are shockable, quote, shockable rhythms. But if they come in and there's no electrical activity, you do chest compressions. You do try to figure out the underlying etiology, but there's no shocking involved, at least in this case. Anything else, Bobby?
No, I'm a little bit shocked that you got that right.
Oh, well, I'll drink to that.
Cheers.
All right. I think we do have one more slide.
Alrighty.
And this is the highest yield of all. So for the listener at home that can't see this, so this is a meme of Jeremy from Top Gear, the British bloke. And the caption says, when you have 3 minutes left in OSCE and the patient tells you that his wife died, and in the top half he says, oh no. And then he looks at the camera and goes, anyways. So it's just a good teaching point for when you have your OSCEs. You got to be empathetic, but you got to get those points.
Got to keep that
There's
show
no
moving.
need of beating around the bush for 5 minutes. Say, oh no, I'm so sorry, check that box off, and get going. How did you like your brew?
It was pretty good. I'd give it like a 7.5 out of 10. It's an IPA, but it's like not very strong, which I like IPAs, but I don't always need them to kind of knock my...
And Bobby, what was the name of the brew again?
It was the Hydro Haze from Warped Wing Brewing Company.
All right, and you gave it a 7.5, correct?
Sure did.
So Beer Advocate rated Hydro Haze is a 3.71.
So that'd be 7.42.
So if you multiply that by 2, oh, that's pretty close actually. What, 7.4-ish? Fantastic.
Yeah. Do you think your hard kombucha has a rating on...
My hard kombucha, so this is the first hard kombucha I've ever had by Flying Embers. So I actually don't know if hard kombucha makes it onto Beer Advocate. This is a first.
That seems outside of their scope.
So I don't really know how to describe it or what to compare it against. I guess I'll compare it against the other brews that I've had. I would definitely drink this again. I would give this probably a 7 out of 10. Okay, so let's see what Untapped said.
If you had to pick an element from the periodic table to describe it, which one would you choose?
I think this is most likely the element beryllium on the periodic table of elements.
Beryllium. Okay, sure. Yeah. Maybe George R.
But anyways, the Untapped rating was 3.64 out of 5, which is similar to yours. So it comes out to essentially 7.2. So pretty similar to what I rated it as. Let's see if there are any funny reviews. I love drinking in the darkness, but it's unusually quiet with just a few cricket frogs stirring. Tasty kombucha, though, my second. Similar to, but much better than hard seltzer. That was by George T.
Thanks, George. Very cool.
All right, guys. I hope you guys found value and enjoyed this episode. As always, if you enjoyed it, smash that like button so others like you can find us and get the same value. If you want to follow us, we're sending out lots of high yield stuff every single day. You can follow us for podcast updates, for video updates. You can check out our website, buzzwordsmed.com, where you can see a slew of practice exams that are only increasing. By February, we should have at least 10 practice exams and much more high yield content to come. All right, guys, have a fantastic rest of your day. Take care.